Okay, good evening everybody, and thank you very much for joining us for what is a very special occasion. Loads of people now have joined online, and I'd also like to say very much welcome to those of you that will be watching on catch-up, because I know a lot of people do so. I'm Jenny Hyam, I'm the Vice-Chancellor of the university, and it's wonderful to showcase academic careers that are also very focused in clinical grounding, and Robert is going to give us an excellent exposition of that. I've already had a sneak preview. There's lots of pictures on the slide, which is something that we're going to enjoy. And another thing that we also have done during this time is realise we overlapped clinically when we were working both at St Mary's. And I think that when you graduate, they always say that the jobs of tomorrow, you don't even know about them today. And that was certainly the case in terms of interventional radiology. When I was at medical school, it was a very static occupation in terms of images. And now, wow, hasn't it expanded and grown? And the skills and the techniques and everything that I'm really looking forward to hearing about this. But it is something that I have been amazed and impressed by, and called on as an emergency service. I mean, it used to be that it was never emergency service in this way, and now it has totally developed. So we are going to hear a lecture that is going to take less than an hour. It's great that so many colleagues have come to the lecture. It's always those that are closest that often are still working right up in the moment until the lecture's delivered. We're then going to not have questions at the end of it. That's one of the things about an inaugural lecture. We hear it, but of course you can ask whatever questions you like over some refreshment, which is just next door. So you'll be directed to the place just in the collaboration space, and there will be nibbles and drinks, but not until Lakshmi is given the vote of thanks. So may I ask you, Professor Morgan, to come and give your lecture, and we very much look forward to hearing from you.
Thank you, Jenny. So, ladies and gentlemen, it's a great pleasure to be here. Took a long time in the planning, but here I'm going to talk to you about interventional radiology, the past, the present, and the future. And I'm going to talk about my role in IR and where we got to and how we got there. So it's in three parts, essentially. I just want to say thank you to Jenny and her staff for all the great work they've done in promoting this. It's been quite disconcerting walking through the medical school for the last 6 weeks and seeing my picture everywhere. It'll be sad. I'll be sad to see it go, but it'll be somebody else's turn soon. I guess no inaugural lecture would be complete without telling you where I've been to get here. So without going through my whole career, I thought just thought I'd go through my interventional radiology career. So I trained in radiology in Plymouth. Then I went to Galveston, Texas to become a fellow, where I stayed for 2 years. And then I went to Guy's Hospital to become a lecturer in interventional radiology with Professor Andy Adam, who's sitting in the second row. I was his second lecturer. Then I went to St Mary's, where Jenny and I met. And then I came back to St George's, where I've been ever since. So the first third of the lecture is essentially a history lesson about interventional radiology. So the father, if you like, of interventional radiology was Charles Dotter, who first described the angioplasty in 1964. He used to do angiography, and he thought, what a good idea when you see a narrowing of the femoral artery like this, wouldn't it be a good idea to dilate it? So he used a series of dilators and eventually got the result you see there. He thought this was great, but the people referring the patients to him didn't. And when he would get referrals, they would say, please visualize, but do not try to fix. So popular, but not popular at that time. The next landmark of IR was development of a catheter with a balloon on it. And Andreas Grinzig was a cardiologist, and I don't know how he managed to do it, but he put a balloon onto a catheter which he could dilate by injecting saline at the proximal end, and he used this to dilate narrowings of the coronary arteries. And I think this is a great picture. This is Andreas Grunzig explaining to a few curious onlookers about the concept of percutaneous coronary angioplasty in the near-empty corridors of the American Heart Conference in November 1976. So they must have all thought he was mad. But from little acorns do great oak trees grow. I'm going to focus in many ways on development of IR societies in Europe and the UK. So in 1985, there were two IR societies. One was European College of Angiography, and the other one was the European Society of Cardiovascular and Interventional Radiology. And these two societies combined their meetings between 1982 and 85. And they were joined during these meetings by the sister society, the Society of Cardiovascular and Interventional Radiology, SCIVA, as we used to call it, now called the SIR. And in 1985, they amalgamated to form the Cardiovascular and Interventional Radiology Society of Europe, called CIRSE. The first CIRSE meeting was held in 1986 and has occurred every year since. And the photograph on the right you see is of 6 CIRSE presidents. Here is David Allison, who was a professor of radiology at Hammersmith Hospital, who many of us know, and I know that Andy worked with him when he was there. And attendances at the CIRSE Congress increased to 800. Early IR in the UK, the first record I could find was this paper by David Sutton, who was a radiologist at St Mary's Hospital, who published this paper on arteriography and renal artery stenosis in the Postgraduate Medical Journal. This is a paper from David Allison on angiodysplasia and Meckel's diverticulum, which he published in 1982. So early footsteps in IR. So the British equivalent of CIRSE, the British Society of Interventional Radiology, held its inaugural meeting in 1988. And a group of IRs from around the UK got together, and they'd seen the example in Europe, and they formed the BSIR. First meeting was in Stratford-upon-Avon, and these were the society aims which you see on the right. So basically learn from each other, liaise with other societies, and focus on education and research. So I went to the third BSIR meeting in 1991. It was a curious affair, 1990. It was a curious affair. It was in Stratford-on-Avon, and it snowed overnight. And nobody could get out the next day. And everybody had to double up and share hotel rooms because there wasn't enough. And it was a great way for a junior registrar, that was in year 3 in radiology, to meet other people at that time. And I wrote this article, Snowed in Stratford, for the Royal College of Radiologists newsletter in 1990. So that was my first experience to the BSIR. So these are early landmarks in interventional radiology. I've mentioned the lower limb angioplasty in 1964. In 1967, people reported treating gastrointestinal hemorrhage with vasoconstrictors introduced down the catheter within the artery, and in 1972, people started injecting material down catheters, which was the early start of embolization. Embolization with pelvic trauma was reported in 1973, and then thrombolysis for arterial and venous occlusions in 1974, and a curious procedure, transhepatic embolization of varices for people with chronic liver disease. And I started to hear about this when I was in medical school. So these are early embolization procedures for GI hemorrhage. On the left, these are cut films. This is the old way of doing angiography. Here's a superior mesenteric arteriogram in a patient with GI bleeding. Here's a blush showing where the site of bleeding was, and you could inject little pieces of gel foam to stop the bleeding. Here's another patient with, this is a inferior mesenteric arteriogram showing a blush of contrast in the colon, and this was treated by injecting little metallic springs called coils. So 2 early GI bleeding cases. In the 80s was the era of the stent, and so we had biliary stents for biliary obstruction, balloon expandable stents and self-expanding stents were developed, and then the stent grafts in the early 90s for use in the abdominal aorta and the thoracic aorta, and we're now starting to get the early procedures for oncology, so embolization, liver tumors, cryoablation to freeze liver tumors, and ethanol ablation at the same time. And then people started using these techniques to treat varicose veins, and we started to get the early reports of uterine fibroid embolization. These are the pioneers of the stents. Cesare Gianturco made this curious stent called the Gianturco stent. Julio Palmas from Texas invented the Palmas stent, which was a balloon expandable stent. So it's basically a stent on a balloon, and you dilate the balloon and then you deploy the stent. And then Hans Wallsten was the father of the wall stent, self-expanding endoprosthesis, and there were many other self-expanding stents which came after that. Juan Parodi, a vascular surgeon, reported the first endovascular aneurysm repair using a stent graft in 1991. Here's a patient with abdominal aortic aneurysm with treatment with a bifurcated aortic endograft, and then a patient with a thoracic type B dissection. Here's a contrast going into this big false lumen, and this was treated by placement of a stent graft. So this was the start of stent grafting for aortic disease, and that has progressed substantially to where we see it today. So there's Professor Belli, third from the left, one of the pioneers of uterine artery embolization, along with Jim Spies and Jean-Pierre Pellage. And they found that with these early embolization techniques, they could embolize all sorts of things, and people with uterine fibroids were found to be suitable for this treatment. If you put a catheter from each groin into the uterine artery and inject embolic agents through a syringe, you could eradicate the flow in the fibroid, and this is actually a very good treatment for uterine fibroids. These are some of my early papers. Early research in interventional radiology was basically centered on efficacy of new devices and new procedures, mainly cohort series. This was a curious study. We would put catheters in the gallbladder, dissolve the gallstones and pull the catheter out. Of course, it never caught on. But it was, I wouldn't even say it was fun doing it at the time. Not for the investigator or the patient, in fact. Then there's this patient with Dave Bree, myself, and Tim Buckingham on combined iliofemoral occlusions from the popliteal artery. These were one of the first reports of popliteal artery access for these lesions. Paper from Texas, draining pancreatic abscesses, and then some work with Andy Adam, closing fistulas and perforations in the esophagus with plastic-covered stents. So that's the early part of IR. The next section will deal with IR development in the last 20 or so years. and it'll focus more on admin and organisation than on clinical advances, but I will deal with clinical advances as you see on this slide. So we had the huge development of drug-eluting devices, drug-eluting stents, drug-eluting balloons, which have changed the way we look at peripheral arterial disease, although not without some controversy. In yellow, you see all sorts of new techniques for the treatment of patients with cancer, and in green, we have a lot of new techniques for embolizing different areas of the body, prostate gland and prostate artery hypertrophy, geniculate artery in patients with osteoarthritis of the knee, hemorrhoid embolization, portal vein interventions, and bariatric embolization of people who need to lose weight. And here's just a vascular malformation procedure, patient with an orbital malformation. This is the patient eye underneath here. You can visualize it with ultrasound, put a tube in and inject material to actually treat the malformation. And Lakshmi in the second row does that, which is a pretty scary procedure, I think. We've seen the maturation, I think, is a reasonable word, for the field of interventional oncology. People found that if you can visualize lesions with ultrasound and put a needle in them, then you could inject material to ablate those tumors, or you can heat them up, or you can cool them down. And the other way is if you put a catheter into the artery supplying the tumor, you can inject chemotherapy agents to kill the tumor. These are some of the pioneers: Sidney Wallace from Houston, Andy Adam from Guy's Thomas's, Yasuaki Hirai from Japan, who is still working, and Peter Mueller from Mass General. I'm going to cover some organizational issues, which, although they're focused on interventional radiology, they probably pertain to all clinical disciplines, because each clinical discipline will have its own society with its own responsibilities. And this will ring true with many of those. So I'm going to talk about education, examination and accreditation. I'll talk about journals for the publication of research, standards and guidelines documents, the public identity of interventional radiology. I'm going to talk about clinical practice for IRs, and I ought to talk about turf issues. So this was CERSI. This was the executive committee in 2003. This was my appearing on the executive committee in CERSI in 2003, where I stayed until last year. I became president of the CERSI Society in 2017 to 2019. I still have some responsibilities with that group. So there's a huge expansion of educational congresses. So in-person live educational events is the sort of way that they're called. So attendance increased from a few hundred in the early slides that I showed you to more than 8,000 per event. And in addition to education and networking, the whole opportunities on research innovations and collaborations. Most importantly, you meet people from around the world and you start thinking, well, what can we do together? So you could say that an interventional radiology community developed. I was lucky enough, because I enjoyed it. I was deputy or chief program chairman for 4 CERSI congresses, which is a huge undertaking, more than 500 lectures. But I always say that if you want to meet people, become a program chairman, because you meet people from all over the world, and you'll never forget them, and they probably won't forget you either. So that was one of my favorite times. And then from general congresses, there became the need for more focused congresses like the ECIO, which is oncology. Guest Europe is embolization. The one at the bottom here is a complications meeting, and I led the creation of the Embolization Therapy Congress in 2018, which has been held ever since. There are many congresses throughout the world, and this is not just interventional radiology. but all are opportunities to show your research and collaborate with other people from your specialty around the world. So that's meetings. Next is examination and accreditation. I'm going to talk about the European Board of Interventional Radiology, or the EBIR. Until 2010, there was no recognised European examination in interventional radiology. The US had developed their own some years before, but certainly Europe was lagging behind that. At the time, IR trainees in UK and Europe were assessed during their radiology training with no separate IR examinations. So I created and led the implementation of the European Board of Interventional Radiology examination for IRs in Europe, called the EBIR, in 2008 and 2009. And the first iteration of this examination was held in 2010. So this was looking back at it now, it was a curious affair. With a small team of people, we created written and oral exams. We selected and trained examiners, and we formed a council for oversight. And this was the first examination, had 22 candidates, and was held in Valencia. These are the candidates taking their written exam, because there's a written exam and an oral exam. And this is a picture of the examiner and the candidate next to him during the oral examination. So this was like a big train that we loaded, and it left the station. And once you load this, sort of get the train running, it will progress and mature, as it has done, as I'll show you in a moment. And I ran 2 of these examinations. The examination was endorsed by the European Union of Medical Specialists, or the EUMS, and the European Society of Radiology. And since 2010, it's undergone substantial evolution. It obtained accreditation by the UEMS SESMA body in 2015, which accredits professional examinations. There's now over 1,000 IBIR holders. This was reached in 2022. And it's now taken by IRs worldwide. It's held in several languages as well. And it's now become digital, so there's no requirement for in-person attendance at a site. It can be all taken online. Most of the holders are in Europe, but as you can see, there are holders all around the world. Wrote a paper about it this year. So History of the IBIR was published in January. To go along with examinations, you need curricula, and the first iteration of the European curriculum and syllabus for interventional radiology was actually coordinated by Professor Belli, and we now have a second edition in existence. There's now a curriculum for interventional oncology, and there will probably be a curriculum for endovascular work as well very soon. In the white, there's a college curriculum on interventional radiology for UK, and there's even a curriculum for medical students. So we want to target our medical students, try and infuse them about interventional radiology during their medical school training, so they become aware of IR, and maybe they might even want to spend time in IR, and who knows, become IRs themselves. Catch them earlier, I guess. I'm current chair of the CERSI Endovascular Subcommittee, which the role of this is to support, promote all aspects of endovascular therapies for IRs. We produced a specialist endovascular certificate in 2021 to support IRs doing endovascular work. And there are IR journals, 3 dedicated interventional radiology scientific journals. I've been editor for the review articles for CVR for many years, and I'm now deputy editor-in-chief for the CVR Endovascular, which is a journal devoted to endovascular work since 2017. Here we are at the launch of CVR Endovascular in 2017, and if you look closely, and I'll help you, and there are several people in the room in this picture. So That's me, Anne-Marie Belly, Ju Shen, and that's me lurking in the back. Next, so we've had journals, we've had meetings, we've had examination. No society worth its salt should avoid writing standards of practice and guidelines for IR procedures. This is an editorial that I wrote with the then editor-in-chief of CVR, of Cardiovascular Interventional Radiology, back in 2004, introducing the topic of guidelines for CERC members. So the aims are to standardise procedural performance upon the IR committee, make sure everybody does the procedures along the same way, has a set, broadly set technical success rates, broadly speaking, accepted number of complications, just so that people perform these procedures to the appropriate standard. There have been 30 of these standards documents since 2001. And when I was SOP chair, I produced 9 and kick-started the procedure or the process back in 2003. And these are just 2 of the documents that have been produced. Looking at what's happened in the UK, the BSIR is a subspecialty of clinical radiology. It's a special interest group of the Royal College of Radiologists and represents UK IRs at the Royal College of Radiologists and in the UK. However, there's no responsibility, or BSIR has no responsibility for the design or implementation of IR training. This is entirely under the control of the Royal College of Radiologists. And it has no responsibility for workforce planning either, which is also under the control of the Royal College of Radiologists. Why do I mention that? I'll come to that later. I've held several roles in the BSIR. I'm currently its vice president and will become president in November. There are also UK guidelines. I'm currently leading the production of the 3rd iteration of the provision of interventional radiology services, which will be published later this year or early next. And I was a co-author on the Vascular Society provision of services of people with vascular disease, which was published in 2021. So guidelines documents are important. And I'm chair of the London IR Working Group, and we recently completed, and which will be published very soon, a document on out-of-hours provision for interventional radiology services across London, stating out where the current gaps are, where the needs, and where it works well. This has been a sort of interesting process, looking at seeing how IR is provided out of hours across London. So, research in academia and IR, what's been achieved since 2000? Well, there's been increased involvement by IRs in research, but these are still mainly cohort series, although we have seen some randomized controlled trials and meta-analyses. There are only 5 interventional radiology chairs in the UK. One of those is a university chair. And there are a few academic IR positions. Of course, the lack of academic IRs results in few IRs apply for research grants. If you don't have protected academic time, then you've got limited time for protected research. And then there's the problem of the limited academic training and support. And it's probably true to say that industry-funded grants favour clinical specialties versus interventional radiologists. Coming on to TURF. It's the slide on the right always makes me smile. We've invented a lot of procedures over the years, and it's not surprising that if you invent a procedure that is used to treat a subset of patients, then the clinical group treating that subset of patients who don't do that their technique anymore feel displaced. So they want to do the procedure that has been developed to do to treat their patients, and not surprising that produces turf issues. There've been turf issues worldwide. It's actually worse in the US and parts of Europe than it is in the UK. It's not bad in the UK, really. Most common tend to be vascular procedures, but also involve many other procedures and specialties. Certainly in the US, there are all sorts of people doing all sorts of procedures in the US. It's mainly, and certainly this is not a UK thing, it's mainly in Europe and the US, but not exclusively driven by financial interests. Where if you get paid to do a procedure, you're going to want to do it and not let somebody else do it. But in general, and this applies to this country mainly, demand by patients will always exceed capacity to provide the procedures, and this mitigates turf issues, and certainly is why we don't have the terrible turf issues that they have elsewhere in this country. Which is not to say that they don't occur. So Dr. Dotter, remember him, back in 1964 said that if we don't assume clinical responsibility for our patients, we will face forfeiture of our territorial rights based solely on imaging equipment others can maintain and skills others can learn. So basically, we can't just be technologists. We've got to take ownership of the patients. We're not just technicians, we have to be clinicians as well, and we have to increase interactions with the patients. So for the last 20 years, there's been a drive to get IRs more involved with patients. Certainly for the last 10 years in St. George's, we've seen patients in outpatient clinics before and after their procedures, and in many places they try and get inpatient bed responsibility. And I was the co-author in this initial first document on clinical practice in IR back in 2007. What's in the name? There was a lot of debate in the early 2000s, basically caused by the fact that nobody knew who interventional radiologists were. You know, there were many surveys of people in the street, what's an interventional radiologist, and people wouldn't know. So we thought, well, can we change our name? Should we call ourselves surgeons in guided surgery, or should we say call ourselves pinhole surgeons? These were described in these landmark lectures in 2004 and 2006. And fortunately, I think in 2023, it's too late, and we're probably stuck with the name interventional radiology. You have to make the best of it. I should mention the COVID pandemic. Lots of things happened in the COVID pandemic. At St. George's, we formed teams and went to put central lines in on the ICU, and we wrote a paper. You see here, the scientific societies produce all sorts of documents, run webinars to try and help people deal with the consequences of lockdown, basically, and the pandemic. I think one of the lasting features of the pandemic was the creation of the virtual meeting, which we have every day in our daily practice, not only in IR, but in every sphere, in fact. So these were a success, although the virtual meeting doesn't replace the face-to-face meeting. I'd like to end this section by thanking everybody for the conferment of the title of professor to me in 2021. I want to thank especially Professor Dorothy Bennett, who was a great help and support to me to get me to this place. And now, the last section, the future. 3 things I want to focus on. Won't keep you much longer. Challenges in interventional radiology. I think that there's always going to be a need for increased recognition for interventional radiology. You still meet people, and it's a favourite trip of mine. You know, you're on holiday, you meet strangers, and you say, "Well, do you know what an interventional radiologist does?" More people know now than they did 10 years ago. So one of the ways to achieve increased recognition would be to achieve specialty status, and I'll tell you why that will help. And if we can't achieve specialty status, then try and achieve components of specialty status, or the bits that make it being a specialty. I think that another challenge is to increase the utilization of IR procedures worldwide. In many countries, due to, in the main, to financial constraints, IR is poorly developed, and patients still don't get access to minimally invasive therapy. And then I'm going to talk about research. Another challenges too, but I've already dealt with that, so I won't talk about that anymore. Specialty status, how would that help? Well, it would give IRs the right to plan workforce strategy to address the severe shortage of IRs. The recent Royal College of Radiology College census confirmed what we already know, that there's a shortage of interventional radiologists to perform in our service and out of our service. So if you have a GI bleed in the middle of the night, you are subject to a postcode lottery depending on where you are. Specialty status would give IRs a better voice in hospitals, certainly commissioning and in government. Specialty status would provide a better public and media profile and may provide ownership of patients to those who want it. There are obstacles to that, not least the Royal College of Radiologists, who are quite happy with things the way they are. But that's not a reason to try and change it. And then radiologists who do both diagnostic and interventional radiology may not want to change the status quo either. We started this process back in 2014. We wrote this paper, this editorial, McLean, Annabelli, Elias, myself and Jim Rikas, specialty status for interventional radiology. The time is now. Well, clearly we don't have it yet, although many countries do. In many countries in Europe, IR is a primary specialty. IR is also a primary specialty in the United States. I wrote this editorial in 2021, Interventional Radiology in the 21st Century, Planning for the Future. In that editorial, I broke it down into 7 parts: work towards specialty status for IR, increase IR trainee NTNs and the IR workforce, increase clinical practice involvement, increase access to inpatient beds, increase IR day case facilities, address competition issues with other specialties, and introduce a certificate for UK IRs, because there's only I would say only, but we have the European IR examination, but this is not adopted officially by the British College. To help this process along, I formed a task force and we wrote these 2 papers, one on day case units, the one from access to inpatient beds, and these are published actually this month in Clinical Radiology. So specialty status, that's one of the challenges. The other challenge, or the second challenge, is globalization of IR, trying to deliver interventional radiology to people in less economically sound countries. And how can we do this? Well, we can collaborate with other international or national IR societies. We want to increase IR development, uptake in all countries, increase access to education and training. To do this, we meet with other people around the globe. These are societies from Japan, India, Central America, China, Asia Pacific, and Brazil. And you meet them and you talk with them and you say, well, how can we help the people in your less well-off part of the world? How can we help? Well, we can we can provide membership, we can provide access to research publications, we can provide Congress registration and access to webinars, either free or at reduced costs. Just one of the many ways that we can do that. I went to Myanmar before the coup in 2019 and 20, and to do a international outreach workshop. We went twice. These were representatives from Japan, US, and Singapore, and I was doing live cases and giving lectures and hands-on courses. So this is just one of the many ways that you can influence people's exposure to IR by just going to them and providing that in-person help. The last section, I'm going to talk about research and academia in IR, and also move this into radiology as well. So there's a need to increase the academic profile of interventional radiology. I already mentioned that there are very few academic interventional radiologists in the UK at all grades, really. To do this, we need to increase or promote the attractiveness of an academic career to interventional radiologists. To do that, I think we need to increase the engagement of universities with IR, but also IR with the universities. I think that needs to happen. How about we achieve this? Well, at a sort of general level, we could have promotional activities on academia at national meetings, sessions on how to write grant applications, how to liaise with your local university or trust research departments, and how to go after sources of research funding in the UK and Europe. We could write more editorials advocating academia and research in IR journals, try and promote grant applications by IRs, but that's difficult. Very useful way is to encourage teaching hospitals to increase collaboration with their partner universities, and St George's has done that. We have TACRI, which is really useful innovation, and I think we're already seeing the help that has provided. We did a quick straw poll. Thank you, Dr. Whale, for doing this. She did a ring round, and there we have one professor of radiology. Remember, I note I've moved from IR to radiology. Bart has one, GOS has two, going up to Imperial, who has set 12. So we're very grateful to have one, but it'd be nice to have more. Obviously, that's up to us to do that for ourselves. Local situation at St George's for radiology. Well, there's no home for interventional or diagnostic radiology in SGUL. There are 6 honorary academics when I last counted within IR and DR, and they're all distributed around various CAGs. So if you look at the brochure you have there, you can find many of them, but you have to look for them. And they're all split between genetics and neurosciences and cardiovascular groupings. So radiology is split around the various parts of the university. We all know that diagnostic and interventional radiology are key requirements for most clinical research. I mean, very little clinical research can take place without some form of imaging. We all know that. And the radiology research group that I lead is a key member of TACRI. We form 25% of the membership, so that implies to me that radiologists are really interested in research and interested to become more involved with research at St George's, both within the trust, but also and especially so within the university. So this is my pitch, ladies and gentlemen. A single grouping within the SGUL structure for radiology, which would be both interventional and diagnostic radiology. I think it would benefit both the trust and the university, provide a focus for all SGOH and SGUL research that involves imaging and interventional radiology. And as I said in the last slide, there's a lot of that. It would further cement links between university and the trust imaging and IR services. Plus, I think if there was this in place, it would certainly incentivize interventional diagnostic radiologists to pursue academia. We already know that they're keen because of their membership of TACRI, and this would incentivize, I think, IRs and DRs to write research grant applications, which we all know that we need money. University needs money, trust needs money, and we need money for research. So research grant applications are the way to this. So if all of that was done, I think it would increase revenue, it would increase prestige for both the university and the trust. Gentlemen, it's been a pleasure to give this lecture to you. Interventional radiology has progressed substantially since its inception to be an essential part of patient care provision. As I've said, IRs have developed clinical practice skills to lose the technician label, which we had not so long ago. But there is still much to do in terms of public recognition, status within the Royal College of Radiologists, research and academia, and a dedicated radiology grouping within SGOL would benefit both SGOL and the Trust. Thank you.
Thank you very much, Rob. I think it just falls to me now to just give a brief few words. Just want to thank Rob for his wonderful lecture, which I think has taken us through the history of interventional radiology. And I just wanted to say a few slightly more personal words about Rob. So for those of you who don't know me, my name is Lakshmi Ratnam. I'm one of the interventional radiology consultants here at St. George's, and I was thinking about what I was going to say, and I realized I've known Rob for over 20 years. So I started as a radiology trainee in St. George's in 2002, and then as an IR fellow, I trained under Rob, and then as a consultant colleague since 2009. And I'd like to say that Rob's been a fantastic colleague. He's always very supportive of his consultant colleagues and his juniors. Despite his experience and knowledge, he's always ready to help everyone else. He's always been very approachable. And I think his junior consultant colleagues have really benefited from all his expertise and his willingness to share that, as well as to support and encourage the rest of us, and to promote everyone else with what they want to do and to support us in our career developments. And that's really been a very fantastic trait of yours, Rob.
Thank you.
And I think as our interventional radiology family has grown, I think we've seen a lot of changes, and Rob has described some of those. And also working closely with Rob when I was clinical lead for radiology and he became clinical director for diagnostics, he's introduced lots of improvements into the department, into the trust at large. I think you've heard a lot about what he's achieved in interventional radiology, which has been immense, and a lot of that has helped the department and the trust reputationally as well. And more recently, a lot of what he's done for research within the department, promoting research in IR, in diagnostic radiology, and also all the collaboration that's happening with the university, which I think is leading to lots more exciting developments. It's really nice to see so many people here today to celebrate this achievement. And I think we've got a little something that we've got for Rob, that's from all of us, from his radiology family. Let's just to present that.
Thank you.
Congratulations.
Thank you very much. It was an absolute pleasure to be here.